Tu nous vois ou tu ne vois pas?
Non,
Dr. Terence, do you see Laurent or not on? Because I don't see Laurent on the panel.
Yeah, I'm just waiting to. I could not see him also. Just waiting for him.
Terence, Terence.
Yeah, tell me, Vijay.
Yeah, how long will you?
Can we start?
Mais t'as pas checké avant tout ça?
mais si, bien sûr que j'ai checké avant.
Yes, duration.
De refaire quoi?
The first talk will be Dr. Laurel will speak about the anatomy.
Yes, I know, but yes, you can speak about anatomy, Vijay, or because I don't know where is Laurent.
Or we can start with Patrick, who can go ahead with the clinical diagnosis.
Okay.
And by then, if he comes, we can ask him with the second talk.
Okay.
Can we start?
Yeah.
I'll have Professor Dr. Selvaraj to have a few words, and then probably we can start with the meeting. Good evening and welcome you all to this second seminar of the Journal of Hand and Microsurgery in association with the Indian Orthopaedic Association, Orthopaedic Association of South Indian States of and the Tamil Nadu Orthopaedic Association and Tirchi Ortho Club. On behalf of all of you, we welcome you to this interesting topic, distal radial joint and triangular fibular cartilage injuries. To begin with, we having Professor Dr. Selvaraj, who has accepted our invitation to be the panelist and also to give a few introductory words about this seminar, and then probably we'll go to Dr. Patrick to start the seminar. Dr. Selvaraj, please.
Good evening, everyone. I must thank my dear friend, Dr. Terence, the editor-in-chief of the Journal of Hand and Microsurgery, for giving me this opportunity to inaugurate and talk a few words on this session, injuries of the distal radial joint and TFCC injuries. Very often they are neglected injuries and the patient have a lot of disability which goes undetected. And for an average orthopedic surgeon, this is totally Greek and Latin. They don't understand the implications. Just see the X-ray. They do not understand that unless you manage these injuries properly, the hand and the wrist are never going to have a satisfactory function. I am sure this will throw a lot of light into the neglected of the wrist injuries. With these few words, and Terence has organized a very good international faculty to talk on the various topics of this difficult, rather less understood area. With these few words, I have a great pleasure in inaugurating the webinar, and I wish this journal club a grand success. Thank you very much. Over to you, Terence.
Thank you very much for your kind words and appreciation. Sir will be leaving to another important meeting, so we will be having Sir with us for a few minutes. With this brief introduction, we'll go to Dr. Patrick, who can start with the first topic of clinical diagnosis. Patrick, go ahead.
Okay. Thank you very much, Dr. Terence. Can you see my screen now? Yeah.
Perfect.
Okay. So during the last 2 decades, an increased knowledge of functional anatomy and pathophysiology of the TFCC, and also technical refinements in arthroscopic and surgical repair of the TFCC have contributed to a great change of the surgeon's perspective toward the DRUJ pathology. So clinically, a complete evaluation needs an extremely thorough history and, of course, physical examination. Physical examination should always include the unaffected site for comparison. In the acute fracture setting, the mechanism of the injury... Oh, sorry. I need to move that one. Yeah. The mechanism of injury should be elicited because high-energy injuries are often associated with more severe fractures or worse outcomes. So physical examination in acute injury is limited by pain, swelling, ecchymosis, and wrist deformity are always observed. During surgery, after radial fixation of the distal radius fracture, the distal radioulnar joint must be tested by stability. Forearm rotation and DRUJ ballotment should be similar to the normal side. Crepitus, grinding, or clunking may indicate a malreduction or implant malposition and involves in a careful reevaluation of reduction and fixation of the bone. An unstable DRUJ may benefit from slightly increased radial distraction during the fixation, because overcorrection of the radial height indirectly shortens the ulna and tightens the interosseous membrane and the radioulnar ligaments. Diagnosis of chronic DRUJ instability is challenging because signs and symptoms are often unclear. Patients may report frank episodes of DRUJ dislocation, but more commonly pain and loss of function are presenting complaints. Patients may report difficulty lifting objects or clinking with forearm rotation. Examination should identify sites of tenderness and gross deformity. A subluxing ulnar head may be preeminent dorsally, or the caput ulnar syndrome may be present. The patient is asked to position the wrist to reproduce the pain. The examiner should listen for a clunk. Wrist range of motion must be compared with the injured site. UCU subluxation and foveal tenderness should be checked. Grip and pinch strength should be tested bilaterally. 3 different signs. The first one is the piano case sign, described as a dorsal resting position of the ulna that translates volar with applied stress. There is a very nice sensitivity, but a short specificity for this sign. Volar subluxation produces slight fullness on the volar aspect on the wrist with the depression dorsally. Subluxation is more subtle and difficult to detect than is with the contralateral, suppose normal site, especially because normal laxity differs considerably among individuals. Point tenderness is common over the fovea, which is located between the styloid process and the FC. The forearm in neutral position. Shocking the ulna relative to the radius is painful and or grossly unstable in symptomatic patients. To perform this test, the examiner holds the distal radius fixed while applying alternating dorsal and volar forces to the mobile distal ulna. High specificity, but only moderate sensitivity. Because more laxity is naturally present with the forearm in neutral rotation, accuracy can be improved by also testing in pronation or in supination. This test can be performed with injection of a local anesthetic to eliminate the pain. The third one, and the more nice, is performed by having the patient push up with the affected wrist from a seated position using the armrest, which causes exacerbation of ulnar-sided wrist pain. The test was reported to have a sensitivity of 100% for the diagnosis of TFCC injuries. A modification described by Adams as the patient remains seated and applied toward force to the examination table located in front of the patient. Comparatively increased depression of the ulnar head on the affected side shows instability. This is the test, as you can see. So now I'll speak to Frederick for imaging and the different possibilities. Thank you.
Thank you. Thank you, Dr. Patrick. We will have the second talk. Meanwhile, we have the panel.
I think Laurent is with us. Maybe Laurent can speak about anatomy.
Perfect. So,
Laurent, tu nous entends? No, Frédéric. So.
Can you see my slides?
Yeah.
Okay. Hello. First of all, I would like to thank the organizer, Dr. Terence, for inviting me to talk about TFCC imagery, and of course, Dr. Patrick Couvet. The TFCC is made up of several elements, which are the articular disc that you can see here in yellow, the radioulnar ligaments, also in yellow, the dorsal and palmar radioulnar ligaments, with their insertion on the fovea here and on the styloid process here. The ulnocarpal ligament also, ulno-lunar and ulno-triquetral. And finally, the meniscus. As you can see on this MRI and on this CT arthrography, you can distinguish the articular disc just here and here on this CT arthrography. You can also distinguish the foveal insertion of the TFCC and its styloid insertion, and finally the meniscus here. On sagittal view, you can see the dorsal and the palmar radioulnar ligament. Here you have the dorsal ligament, and here the palmar ligaments, and here the articular disc. So the dorsal and palmar ligament are surrounding the articular disc. Here on MRI and here on CT arthrography, you can see the palmar and the dorsal radioulnar ligaments. You can also distinguish the ulnocarpal ligaments. You have here on this sagittal view of CT arthrography the articular disc, and here you have the ulnocarpal ligament, ulno-lunar and ulno-triquetral. You can see here the pisiform and here the triquetrum. TFCC has two major functions. First, it stabilizes the radioulnar joints via the radioulnar ligaments and their foveal insertion, just here, in association with the ulnocarpal ligaments, which also participate in joint stability. This is what we call the proximal components of the TFCC. Second, it participates in shock absorption to the ulnar side of the wrist via the articular disc, the styloid insertion of the TFCC, and the meniscus. This is what we call the distal components of the TFCC, just here. Depending on the structure involved and its function, the management will be different. So damage to structures involved in stabilizing the wrist should be repaired as much as possible by surgery, while the structures involved in shock absorption will instead be subject to debridement. So there are two pathological contexts. First, a traumatic context where the movement involved is often an extension and pronation of the wrist, as you can see in certain sports like tennis, golf, or fencing. And second, a degenerative context where the determining element is the presence of a positive ulnar variance, which will increase the stresses on the ulnar side of the wrist. We use the Palmer classification with two classes. Class 1 lesion corresponding to traumatic lesion, for which the fourth stage classification has been refined by ATZEI, depending on the anatomical site of the lesion, and class 2 lesion which correspond to degenerative lesion, also called ulnar impaction syndrome, with 5 stages of increasing severity. So let's start with class 1 lesion, the traumatic injury. It may be a class 1E lesion, which only involve the articular disc, which means a structure involved in the absorption of shocks and stresses and without stabilizer function. You can see on this CT arthrography a perforation of the articular disc here, just here, and on the contrary, respect of dorsal and palmar radioulnar ligaments. Class 1B lesion may involve the foveal insertion of the radioulnar ligaments or the styloid insertion of the TFCC, which are two structures different, belonging for the first one to the proximal component and for the second to the distal component of the TFCC. So they have two different functions and the treatment will be completely different. The lesion, of course, can also affect both components simultaneously. Here is, you can see on these images, a few lesions. You have a lesion of the styloid insertion of the TFCC here on this MRI. Here you have a lesion of the foveal insertion of the CT arthrography, and here on MRI you have a lesion of the foveal insertion of the TFCC. And here you have a complete lesion of the TFCC, a tear at the foveal insertion and at the styloid insertion. And you can notice also a perforation of the articular disc just here. Class 1C lesions are difficult to diagnose. They concern the ulnocarpal ligaments, ulno-lunar, and ulno-triquetral, which this ligament participates in stability of the distal radioulnar joint. You can see here an example on this MRI. It's an arthro-MRI with a tear at the insertion of the ulnolunate ligament just here on this frontal view and here on this sagittal view. Diagnose this lesion are very difficult. Class 1D lesion involves the radial insertion of the TFCC, as you can see here on this frontal view and on this axial view. On this class 1D lesion, the distinction must be made between isolated lesion of the articular disc, which don't have a stabilizing function, and lesions which extend to the palmar or dorsal radioulnar ligament, or both of them, and which compromise joint stability. And again, there are two different function structure and two different treatments. You can see a few lesions here. You have a 1D lesion here with radial tear at the radial insertion of the articular disc here on this central image. And on the contrary, the dorsal radioulnar ligament and the palmar radioulnar ligament are completely respected. Here also a 1D, class 1D lesion. You can see on this image is perforation of the articular disc here, just here. And you can see that the lesion extends to the dorsal radioulnar ligament on this frontal view. And just here you can see that the lesion extends to the dorsal radioulnar ligament. So here is a summary of class 1 traumatic injury, where the classification is based on the anatomical location of the injury. In class 1B and 1D lesion, it is very necessary to know whether the lesion can compromise the stability of the wrists. In class 1B lesion, it is very important to know whether the lesion concern the foveal insertion of the TFCC. And in class 1D lesion, it is very important to know if the lesion is limited to the articular disc or if it extends to the distal radioulnar ligament, here dorsal ligament, and here palmar ligaments. We can continue with class 2 degenerative lesion, also called ulnar impaction syndrome. They are favored by positive ulnar variants and progress in 5 stages of increasing severity. So first, class 2A lesion, it's just a thinning of the articular disc. In class 2B lesion, there is appearance of ulnar or lunar chondropathy. Class 2C lesion, there is a disc perforation. Class 2D lesion, you have a perforation or tear on the lunotriquetral ligament, as you can see here. And class 2E, there is a radiocarpal or radioulnar distal osteoarthritis. There you can see a few lesions. On the left side, you have a class 2C lesion with the perforation of the articular disc, and you can see also chondropathy on the ulnar head, just here. Here you have a class 2D lesion with the perforation of the articular disc, a tear of the lunotriquetral ligaments, chondropathy here on the ulnar head, and chondropathy on the lunate. Another one, here class 2D lesion with perforation of the articular disc, little tear on the lunotriquetral ligaments, chondropathy of the ulnar head with bone edema here. And you can also notice that there is a ulnar positive variance. The radiological assessments always include radiographic images with a frontal view in pronation and may include, depending on the case, a CT arthrography or MR arthrography or just MRI. We will look first for positive ulnar variants. If the lesion concerns radial insertion, it is necessary to specify whether it also concerns the ligaments or if it only affects the disc, it's important. And if it's on the ulnar side, does it concern the proximal or the distal component or both of them? Of course, it will be necessary to evaluate the articular cartilages. You may know that there are some pitfalls, in particular the ulnar pre-styloid recess. It's a little recess between the styloid insertion of the TFCC and the meniscus, a little recess here. And you can see on MRI this recess as a hypersignal. The second pitfall is a hypersignal that you can see sometimes between the two bundles of the TFCC, two bundles on the foveal insertion of the TFCC, the foveal insertion and the styloid insertion. This hypersignal corresponding to ligaments, which is called the ligamentum subcruentum. We can also observe a hypersignal at the radial insertion of the articular disc, like here, related to presence of hyaline cartilage, which should not be confused with perforation, as you can see here on this CT arthrography. It's a perforation, and it's only cartilage. Finally, it should be remembered that the TFCC anomaly is not always symptomatic, and that it's necessary to always opacify the three major compartments of the wrists in CT arthrography or MR arthrography because there are lesions isolated from only one of the two proximal or distal components of the ulnar incision of the TFCC, and you can't see them if you only inject one compartment, only one compartment. Thank you for your attention, and now Dr. Didier Fontès will talk you about arthroscopy, I think. Thank you very much.
Thank you, Dr. Seitun, and the previous about the topic. Can we go ahead to the anatomy if Dr. Laurent is there? I mean, can we start with?
I don't know where is Laurent. I think he do have a problem with his Wi-Fi network, and that's what he exactly told, because he's not in Paris but outside Paris, and he tried to find another place to get a better network.
Est-ce que tu sais si Laurent est dans la clinique par hasard?
Non, il n'est pas dans la clinique, il est à Cahors. C'est un peu loin.
Okay, we'll go with the other topic, by Dr. Didier Fontès. Please go ahead.
Okay, thank you very much for this kind invitation for this worldwide webinar. So we'll speak about the interest of arthroscopy in the DRUJ pathology. First of all, as described by Frédéric Zetoun, there is two main roles for this TFCC. First, it is a shock absorber. And as soon as you can experience a fall down on the outstretched hand, you can have a central lesion, essentially central lesion of the TFC. But sometimes in over-twist trauma, you can experience some peripheral lesion because the TFC is a main stabilizer of the DRUJ. So it's a two main way to observe traumatic lesion of this ligament. As described by Frédéric, Andrew Palmer has described in 1989 the first description for these traumatic lesions, but the 1B and 1D lesion, as described too by Zetoun, have been updated. Concerning the 1B lesion, it is essentially the foveal lesions which are very interesting. And Andrea ATZEI, with the EWAS Society, has defined two classes. So class 2, when there is a complete tear of the foveal attachment of the TFC, and a class 3, where there is only the proximal lesion of the TFC. Regarding 1D lesion, as it is previously said, it's very important to assess the location, the precise location of the lesion. Generally, it's a central lesion. It is on the non-vascular disc of the TFC, but sometimes it can go volar, dorsal, or complete lesion, but sometimes with little piece of bone during fractures. So it's very important to have good assessment of this type of lesion to define the accurate classification of the lesion. As you know, it's also important to assess ulnar variance, because normally for a neutral variance, there is ulnar load inferior to 20% of the total of the loads. But as soon as the ulnar variance increases, you can observe up to 40% of ulnar load. So it's very important to assess this ulnar variance with very good X-ray to know where there is or no an overload on the ulnar side of the wrist. You know, arthroscopy is probably the best way to assess the TFCC. It can give a good exploration for the texture of the ligament. We can assess the classical trampoline sign. Sometimes you will find some holes inside. So it's very important. It is really the best way because it's a dynamic way to assess the TFC. Concerning the foveal lesions, André ATZEI has described the hook sign. When you pull upward and radially with the probe, the TFC, and you can observe this wave effect as soon. It is typically the consequence of a total avulsion of the foveal attachment of the TFCC. But sometimes the lesion is only proximal, and we have described the ghost sign. So the probe is introduced into the DRUJ, and we can have like a ghost waving under a sheet under the TFC, and especially on the ulnar aspect of the attachment. It's very typical of this proximal unique lesion of the TFCC. But sometimes the exploration was not sufficient, and it should be necessary to have a DRUJ exploration. It's not the most simple technique to do, but in case of DRUJ instability, you have a larger space, and you can so easily observe here the TFCC foveal attachment of your ligament. So after this exploration, you will have the diagnosis of your type of lesion, and you have a specific semiology, arthroscopic semiology, when the different signs concerning the different lesions of your ligament. So what is the strategic therapeutic? Patrick will speak about it, but of course it depends on the location and on the vascularization or not of the lesion. And also it's important to know whether there is or not a DRUJ instability, or if the lesion is at risk of instability. And sometimes also it can be associated with radius fracture. So these patterns are very important to the decision. First of all, the therapeutic attitude will be based on histopathology. For radial lesion, palmar 1D, or central lesion, palmar 1A, they are situated in non-vascularized and shock-absorbing area. So we can propose only a debridement. You have to know that we can debride up to 2/3 of the central disc with no instability of the DRUJ. So the debridement can be a good idea, considering peripheral lesions situated in vascularized and stabilizing area. So we will have to do an attempt of suture. It can be open or arthroscopic. But why to debride the TFCC? You know there is no vascularization and there is no innervation too. So why is it painful? In fact, it is painful because of the synovitis which is around it. And first of all, the medical treatment can be proposed with the corticoid injection, for example. But if the treatment is not good, of course, it will create a meniscus-like syndrome that we can observe in the knee when there is a lesion of the meniscus. In fact, it is like a little pebble in your shoe. So when you have a pebble in your shoe, you want to remove it. And also, it's only for histologic reasons, depending on TFCC vascularization. If you have no vascularization, you have no opportunity to observe spontaneous healing of your ligament. And also, for biomechanical reasons, because as you see, when you debride the TFCC, you decrease the ulnar load on the ulnar side. So how to debride? We will use the classical installation for arthroscopy. For us, we do prefer the tour de Whipple tower for this procedure. The scope is introduced in the 3-4 portal, very classical, and instruments in the 4, 5, or 6R portals. So it's very classical for the exploration of the radiocarpal space. Our preference is for the radiofrequency devices. It's very, very easy. You see here, it's a 1A lesion. We begin to debride on the radial side, and you see it's very, very short procedure and very, very precise, very accurate. The only problem is the bubbles that you have to spear with a needle. And you can debride all the central portion of your TFCC with this type of technique. It's a real time. You do that in 2 or 3 minutes at maximum. So it's very easy, and you can do a very complete debridement of all this non-vascularized lesion. But as soon as the lesion is more dorsal on the 1D2, so it's not the same problem. You will have to attend for reattachment. So it's not normal to do a surgical open procedure. And I think that Patrick Houvet will speak about that. But if you prefer, you will have to do an arthroscopic procedure. And we have described the one that I will describe more precisely for the foveal reattachment. And we will use this type of devices, mini-pushlock devices, to reattach it on the radial rim. It's the same thing when the weather is volar or complete, 1D1, 1D4, so you will have to reattach it, and you can do that completely arthroscopically too. Sometimes when it is associated with a fracture, it can be easy to put a little KY like that. So you have to assess this ulnar side as soon as you have a fracture, as you know, because the patients generally experience pain, post-operative pain on the ulnar side of the wrist, not on the radial side after a radius fracture. So it's very important to assess the TFCC during every fracture of the distal radius. Concerning the foveal lesions, it's very important first to have a good diagnosis, and Frederic has shown you how to have a good exploration with MRI and arthro-CT scan. So it's very important to have a good technique to reattach it. The first guys who are interested in that were our friends, Italian friends, Andrea ATZEI and Riccardo Lucchetti, who have proposed a mixed arthroscopic and mini-open procedure. So it's very interesting procedures. They have described the reattachment using little anchors, but you have to do a little open. And the other problem is you have a knot inside the articulation, which can be painful and source of mechanical disorders after. Toshi Nakamura has described the transulnar reattachment. So it's very interesting procedure with the use of a little jig, but it's not very easy to put 1 or 2 pins to recover them, to put your suture. It's very long, very tedious, and we reserve it only in class 3 partial lesions when there is no intra-articular lesion, but it's only in the DRUJ. Another very interesting procedure has been proposed by Bill Geissler, but he proposed these devices, which is unfortunately very expensive, and especially the technique was very complicated with more than 14 steps to do that. Even with a good skill of arthroscopy that I think to have, it's very difficult for me to do that. You have 3 portals, you have to recover your suture, it's very complicated. So it was really too complicated and too expensive for me. So it's for that I have described more simple techniques using this type of device, this type of mini-pushlocks from Arthrex company, and with a needle and a fiber wire. So it's very simple and not so expensive. First of all, is to introduce your sutures, your fiber wire inside your needle. It seems easy, but it's not so easy. So it's important to do that. You put your good suture inside it, and then you will use your pushlock. First, you will have to debride the foveal lesion because it's very rare to have an acute lesion to treat immediately. So it's more chronic. So there is bad tissue, synovial tissue. You have to remove it to expose all your fovea, and you will see here complete avulsion of your TFCC with the use of little shaver, full radius shavers. After, you will assess and you can to debride it with a little burr, like we can see here. So you have good view of your foveal only from the 3-4 portal, and you can completely assess the basis of the styloid as the attachment for the attachment of the foveal aspect. Then you will have to do a little hole to prepare the introduction of your anchor. I do prefer this little hole. It gives less debris than this type of drill. And your assistant will do. You have only to be very precise for the orientation of your hole, and then you can assess it with a little probe to be sure there is no fracture. It is very good, and you can control it with an X-ray control. And then it seems very simple. You don't have the 14 steps that's described by Bill Geissler. You introduce your needle 1 centimeter more proximal to the 3-4 portal, and you introduce it inside your TFCC, pulling like that your suture. You do this little turning to recover your stitches, and you don't remove your needle. You have to pull it very few millimeters. You will reintroduce it through 2 millimeters more dorsal. So you recover your suture through the 3-4 portal like that. And then you go on the same thing, more dorsally, to pull back your suture inside the articulation that you can see here. And you just have to pull out with a little punch this suture, and you will have realized very easily a U-shaped suture on the ulnar foveal aspect of the TFCC. So you see, it's very simple. It's percutaneously for the introduction of the needle, and you don't have to do the utilization of different material, very expensive material. So as soon as you have done that, it's quite finished. You introduce the 2 stitches inside the eyelet of the mini-pushlock, and then you will have to refine your little hole that you have previously prepared on the basis of the styloid. You will see it. You introduce your device here, and you will find where you find back the hole. Oh, sorry. And then your assistants just have to put some hemming of the lesion of the device to introduce it completely inside the foveal hole that you have done. You can see here on the left. It's very, very easy. And after, you just have to cut the suture, and you see you have no knot inside, no bad tissue that can create some bad reaction, some adverse reaction. And then you can assess with a probe that you have refined a good trampoline sign, and there is no more hook signs or ghost sign. Sometimes it's necessary to go on to the suture on the dorsal aspect of the lesion, and it's a classical 1B lesion, and for that we use the outside-in technique described by Terry Whipple on the dorsal, on the deep sheath of ECU. Concerning the post-op period, if you have done a debridement, you have no indication to any immobilization. But if you have done a reattachment of your TFCC, we use a long cast like that during 3 weeks, and then we go on with 3 more weeks with a shorter one, and we begin the rehabilitation and return to sport, generally not at 3 weeks, but sometimes we have no choice, and generally after 2 or 3 months after the procedure. So it was for the traumatic lesions. Concerning the ulnar plus syndrome, we just have only some slides about the Wafer procedure. As you know, to decrease the pressure of the ulnar aspect and to recover the normal ulnar load, different options are proposed. The classical shaft osteotomy, it is a Mills procedure. You can do the Fontès and valve osteotomy or the Wafer procedure. The Wafer procedure has been proposed by Feldham in 1992 with an open procedure, but sometimes it can create some impingement on the proximal if there is too large resection, and it's frequent to observe DRUJ arthritis. So this technique was not very, very popular because of that. So it's for that, with different surgeons, we have described the arthroscopic way to do this Wafer procedure. And we use for that classical installation. We have control with a mini fluoroscan, classical portals, 3-4 for the scope, 4, 5, or 6 are for the instruments, and 6U for the outflow. First time is diagnosis. As you have seen on the X-ray, there is an extent of different types of lesions: chondromalacia, lesion of lunotracheal ligament, TFCC lesions. So it's the best way to assess all that, to do that with your arthroscope. And then you will have to do the debridement. And as we do for traumatic lesion, with the debride, we realize the synovectomy with the mini shaver and this type of radiofrequency devices. And then you will have to do a mini acromioplasty of the bombing aspect of the ulnar head. And it's very important to ask your assistant to turn in full supination and full pronation, not to let any beak on the distal extremity of the ulnar after your procedure. So you can reduce the bombing aspect of the ulnar head. You can control that with a scope after, with an arthroscopy, with a fluoroscan. And then it's very simple to have a good rehabilitation 2 or 3 weeks after the surgery and return to sports generally to 3 or 3 months like the previous procedures. So concerning the results of this wafer arthroscopic procedure, it experiences lower complication rate and quicker recoveries than ulnar surgical osteotomy. And we observe generally an improvement of grip strength, arc of motion, and clinical scores. But you will have to wait more than 5 or 6 months to have the definitive results. So it's sometimes rather long, and you have to explain that to your patient. In conclusion, arthroscopy for us is the best way to assess TFCC lesion. All technique, all inside knotless arthroscopic procedures seems to be reproducible for peripheral lesion, accurate and reliable results with a short learning curve. Concerning debridement and wafer, they are very simple techniques and rewarding procedures. For us, arthroscopy is undoubtedly for the gold standard. Thank you very much.
Thank you, Dr. Didier, for your wonderful talk. It's really amazing to have the entire team from, to speak on this interesting DRUJ and TFCC talk. In the meanwhile, the next speaker is Dr. Patrick Hove. Let him have his presentations ready. We actually avoided the introduction of all the speakers just in sake to save the time. We have sent the Zoom link with all our speakers a short brief CV so that they can know by itself. And these French surgeons are very simple and humble. They just want to tell their name and their their work and their schedule. So they are so humble and they're helpful to us in having this webinar. We have a few panelists also here, and a few questions are also in the Q&A sections, which we can take after the final talk from Dr. Patrick. Dr. Patrick, you can go ahead with your talk. You have to unmute Dr. Patrick, please unmute yourself.
Is it better now?
Yeah, perfect. Go ahead.
Okay, just one moment. Is it good for you?
Yeah, perfect. Go ahead.
Yeah. Thank you, Didier, for this nice talk with your perfect mastery describing all the different specific technique using arthroscopy possibilities. Even if you talk about the different classics possibilities, I'd like to describe you the current treatment protocol for all these different injuries of the distal radioulnar joint. So kinetic dysfunction of the distal radioulnar joint are, as you know, multifactorial and may be caused by a variety of pathologies. The spectrum of clinical condition that may cause this dysfunction is so wide that no classification can be comprehensive enough to include all of them. Nakamura distinguished between acute, that means less than 6 months, or chronic instabilities more than 6 months, but many authors do not consider this definition as relevant for a treatment strategy. Instabilities of the joint may be caused by osseous or primarily soft tissue lesions. Distal radius fractures with or without avulsion of the ulnar styloid process or forced forearm rotation are responsible for the majority of the instabilities.
Dr.
And
Patrick,
regarding...
Sorry.
Yes?
Please share your screen. Please share. We could not see your screen.
Oh.
Share your screen, please.
No. Oh, yeah. So you don't see my first...
No. Yeah. You can start with the first slide. You can go ahead.
Okay. Is it okay now?
Yes. Perfect.
Okay, I'll go back. Did you see the first diapo or not?
We are seeing a slide.
Did you see, now you see all the slides?
No, we cannot see it.
Why that?
C'est très flou et t'as pas fait l'écran total, voilà.
Yeah, it's getting better now.
C'est flou là aussi? Is it okay now?
It's better now. It's still unclear.
Why? I know. At the beginning, I put something with the video. Is it the reason?
You can start.
I don't know. I don't know how to change the.
You can close. You can start from the first if you want.
Is it better now?
Yeah, it's better. It is better.
Is it better now?
Yeah, perfect.
Okay, great. So as I told, instabilities of the joint may be caused by osseous or soft tissue lesions, distal radius fractures with or without avulsion of the styloid are responsible for the majority of the joint instabilities. And regarding soft tissues, basic pathology of most dysfunction of the joint is complete detachment of the TFCC, as told you, my friend Didier. So distal radius fracture plus or minus osseous avulsion of the TFCC is the first part. This is different pictures with and without reparation. Avulsion of the ulnar styloid process are suspicious of joint instability and should be dealt during the procedure. Examination of the joint stability is mandatory during the surgery after fixation of the distal radius fractures. After reduction and internal fixation of the fracture, the ballotment test that I described is performed dynamically in different rotational position of the forearm. Refixation of the ulnar styloid is mandatory in case of instability. Afterwards, immobilization in neutral form rotation is recommended for 2 or 3 weeks with the long arm cast. Soft tissue injuries and detachment of the TFCC. I'd like to evoke the 4-leaf clover algorithm described by Marc Garcia-Elias. That is a tool that acts as a checkpoint to ensure that all the different components are addressed to improve clinical outcomes. It's very important to realize that 4 different pathologies, TFCC injury, bone deformity, cartilage damage, and UCU instability are not mutually exclusive. One patient may have one or more of these associated local pathologies. So there are a myriad of different clinical conditions. Every one of these multiple situations deserves a specific treatment. And this is a Venn diagram, and it represents the different combinations of pathologies that may be present in the joint dysfunction. Most treatment combinations are possible in that joint, and you can see all the different possibilities. A lot have been described by Didier, but the traditional one, of course, all of these different possibilities. How to use this 4-leaf clover algorithm? Physician must examine the patient and from the accompanying radiograph or CT scanner, answer yes or no to the following 4 questions. Is there any bone deformity and or radioulnar length discrepancy that could have influenced the development of the dysfunction? Second one, is there any cartilage defect? Is there a TFCC injury? And finally, is there an easily luxable UCU tendon? Once the answers are known, the surgeon needs to use the Venn diagram and place a check mark, yes or no, for the 4 questions. It determines what is the overlapping zone that best describes that specific patient, and finally apply the combinations of different treatments that best fulfills the needs of the patient sharing the overlapping zone. Circle A The circle contains the joint dysfunction cases with a bony deformity in the form of a distal radius malunion or a radioulnar length discrepancy, as you can see here. If the shape and orientation of one of the articulating surfaces do not match the other corresponding surface, a joint incongruity and a painful synovitis will emerge. To solve this problem, the bone deformity needs to be corrected by even an ulnar shortening osteotomy, as a Milch osteotomy, or a wedge osteotomy of the distal radius, or both procedures. To address ulnar impaction, both Wafer procedures and ulnar shortening osteotomies can be performed with good results. Circle B, if the cartilage is badly damaged by chronic dysfunction or if the joint lost its mechanical properties, osteoarthritis may follow. And this can be addressed by a myriad of different procedures well known, including a resection arthroplasty, direct resection, Borres hemiresection interposition arthroplasty, Watson match ulnar procedure, or Sauvé-Caponghi procedure, or a partial hemiarthroplasty if the TFCC is intact or easily repairable, or even by a hemiarthroplasty. Circle C, in this case, the joint dysfunction results from an unrepairable ligament or TFCC rupture. Dorsal and palmar distal radioulnar ligaments are injured, as Frederick showed you, and ulnocarpal ligaments may be torn. You can use very easily and perfectly with a good result the Adamant-Berger ligamentoplasty, as you can see on this picture. Circle D, this is an unstable UCU case. Usually, joint dysfunction are associated with a rupture or an insufficiency of the UCU sheath. UCU tends to get recurrent dislocation medially and palmarly because it is difficult for it to exert its role of a dynamic joint stabilizer. So tendon stabilization via reconstruction of the UCU tendon sheath may be necessary, or using a ligamentoplasty. Most kinetic dysfunction of the joint have more than one associated pathologies, of course, each of which requires specific treatments. Those cases will be located in overlapping zones, which necessitates a combination of treatments. For example, if one patient belongs to the intersection between A and D, that patient should be treated by the combination of a corrective osteotomy and a UCU tendon stabilization. If instead a patient belongs to a overlapping B, C, D, for example, the treatments need to address the cartilage, the ligament, and the UCU injuries. Treatments may include a partial ulnar head arthroplasty plus a reconstruction of the radioulnar carpal ligaments, and then a stabilization of the UCU tendon. In case of a single pathology, patient has an isolated cause of pathology, so treatment is dedicated to addressing that particular disorder. If the DRUJ is unstable because of a distal radial malunion, a corrective osteotomy should be performed first, and normally the joint becomes fully stable once the malalignment has been addressed. Isolated cartilage defects of the ulnar head or sigmoid notch are not rare and can be treated with a myriad of procedures, including distal ulnar excision, or Watson, or arthrodesis with distal ulnar osteotomy, that is the Sauvé-Caponghi procedure, or even prosthetic arthroplasty. If the patient has an isolated symptomatic TFCC injury, this will need to be repaired or reconstructed. The classification proposed by ATZEI and described by Didier and Frederick is helpful in guiding treatment because it considers the reparative potential of the TFCC, the state of the cartilage, and the stability of the DRUJ. If the patients present with symptomatic UCU subluxation, even dislocation, treatment will be focused on a local capsuloplasty or retinoauricular sling reconstruction by a ligamentoplasty. In case of dual pathology, when the patient has when two different circles of the Venn diagram are affected, The algorithm is based on the assumption that the treatment of an associated pathology is the same. So if the DRUJ instability occurs in the setting of a distal radial fracture, attention must be paid to anatomic fixation to the fracture, including the sigmoid notch. If a distal fracture of the radius has resulted in a joint instability with an irreparable TFCC, this can be addressed by combining a corrective osteotomy with a tendon reconstruction of the two radioulnar ligaments. If the distal radius is deformed and the joint has developed osteoarthritis, this can be addressed by combining a corrective osteotomy and a partial hemiarthroplasty of the joint. Finally, if a patient presents a symptomatic distal radius malunion with UCU subluxation, this can be addressed in a single operation with a distal radius corrective osteotomy and a UCU sheath reconstruction. If you have 3 or 4 pathologies using the four-leaf clover algorithm, one identifies all the pathologies coexisting in the same wrist and tries to treat all of them as they were isolated injuries. Despite this, it's important to recognize that in trying to address all the pathologies, the surgeon must perform an operation that can rapidly address the patient's symptom with a definite procedure. So as such, in certain circumstances, we can perform with a one-salvage procedure. So in conclusion, that algorithm is not a document forcing the surgeon to adopt one particular treatment, but all the different, that classical treatment and well-known treatment can be used. It purposes to provide the treating physician with a checklist that helps to ensure that one does not miss any of the different components that need to be addressed for complete and perfect treatment. And it's a matter of addressing every component as it were an isolated injury with the aim to solve finally all the components. For conclusion, because of its osseous geometry, the distal joint is an unstable joint. The soft tissues surrounding this joint must contribute significantly to joint stability. So a proper understanding of that complex anatomy and function of the distal radioulnar joint is essential for the treating clinician. Chronic instability of the joint continues to challenge orthopedic surgeons, and finally, the definitive surgical treatment of this instability or these instabilities remains controversial. Thank you.
Thank you, Dr. Patrick, for your excellent brief discussion about the very important and less known about the DRUJ and TFCC injury. So we can have questions so that the panelists can start the questions and then they can mediate to the speakers.
Yeah, Terence. Hello.
Go ahead.
Yeah, Terence, I have one question to all panelists. In chronic wrist pain, which is the choice of investigation apart from X-ray? Whether it is MR, is a CT arthrogram, or is a MR arthrogram? Which is the preferable mode of investigation, individual preferred?
For me,
Maybe for
all. Individual.
I answered on the chat. I prefer CT arthrography because I think it's better. The slides are more thin, and I prefer CT arthrography than MR arthrography. That is very complicated, and I think it's better than MRI.
Personally, I will ask for classic and standard X-rays, of course. And CT arthroscanner too, yes, because depending on the quality, of course, of the exam, but if you have a very good radiologist, you will perfectly see the lesion because the different frames are each millimeters, so the precision is very interesting.
For me, the same thing. First of all, is a plain X-rays to assess the ulnar variance. As you have seen, it's very important for the decision. And secondary, if you suspect any lesion of the TFC or to assess the cartilage, I do prefer arthro-CT scan. I know it's not very popular in other countries rather than France, but because there is, of course, an irradiation consequence of the CT scan, but it gives for us very thin exploration and very nice explorations. But MRI can be helpful too in the ulnar plus syndrome, because we can assess also all the ulnar plus lesions with the different variants in T2 sequences, and so it's very interesting too. But for us, arthro-CT scan is probably the best exam.
Yes, and for me too. We can see the cartilage is better than with MRI.
Yeah.
Can you get easily arthro-CT scanner or VJ in India?
Yeah. I do arthro-CT scan only. That's why I asked the question. In India, I use arthro-CT only.
You prefer also arthro-CT scan?
Yes. I do arthro-CT scan. That's why I asked the question. Because you told that it is not popular in the rest of the world, but in India, I do the CT arthrogram only. If it is not, then I will go for MRI for soft tissue. But for a joint and ligament injury, cartilage injury, I prefer CT arthrogram.
Okay. Well said, Vijay. Vijay is motivating many of the young surgeons in India to do CT orthography, and I'm also started doing CT orthography for all these injuries, and it's really very helpful and useful. The other question is to Dr. Fontès. What technique do you use with intact peripheral TFCC injury and pure foveal detachment? This is a question from Philip Matthew. I'll repeat the question. What technique do you use with intact peripheral TFCC and pure foveal detachment?
In fact, if you have no peripheral lesions, the foveal attachment is the convenience of the two volar and dorsal ligaments. Also, if there is no tear of these ligaments, it's that the lesion is only on the central portion of the TFCC. So in these cases, it's only necessary to do a debridement if you do something. But if the lesion goes to the attachment of the ligaments, because the foveal attachment is the attachment of the ligaments, the volar and dorsal, and if there is a lesion at this area, so it should be necessary to retach it.
Thank you. I hope you understand. You answered the question. Other question from Augusto from Italy. He said, when I see a patient with suspicion of TFCC lesion, is it better to request a normal MRI or a MRI with a contrast? The question from Agostino from Italy to the panelist.
Ouvre ton micro, Fred.
Unmute yourself. Dr. Frederick, unmute yourself, please.
Yes, excuse me. It's the same answer. I prefer CT arthrography or MRI, and I don't do a lot of arthro MRI. It's long. We must do 3 injections, so I prefer doing 3 injections with CT arthrography, even for the attachment of the TFCC.
Okay.
I think it's better. We can see everything: the foveal insertion, the styloid insertion, the cartilages. I prefer CT arthrography.
Yeah, perfect. Yeah, Arjo, please unmute yourself.
Yeah, I wanted to ask Dr. DT that what is your take when there is a TFCC injury associated with ATZEI lopresti? Interosseous membrane is injured. So is there anything you could throw light on?
No, it's a very interesting question because, as you know, in ATZEI lopresti lesion, you have generally a fracture of the proximal radial head and a lesion of the interosseous membrane and TFCC lesion, very frequent too. So in my experience, when I have a Mason 1 or 2 fracture of the radial head, I do arthroscopy reduction of the fracture with a little and synthesis with a little screw. So I do that with arthroscopy. And at the same time, if the patient experiences any pain on the wrist, and if you during the exam you will find some instability, I do also an assessment with an arthroscopy of the wrist. And sometimes I had these cases a few weeks ago. I had to reattach a TFC for a foveal lesion because it's more frequently peripheral lesions rather than central lesions. And it's very interesting to assess systematically the wrist and specifically the TFCC when you have any fracture of the radial head. Very good question.
Yeah, very good. Can I have the other question to the panelists? This question is from Dr. Uma Shankar Raju. A very common questions from all orthopedic surgeons across the world. In a galaxy type of fractures with the distal radioulnar joint subluxed, when we fix the distal radius, if you find the DRUJ is still subluxating or not reduced, we need to put a Kirschner wire, and how long we should immobilize, and in what position. This is a common question. Probably all the panelists can go ahead with the opinion.
Patrick?
Well, personally, when I have to treat a Galeas fracture, and if there is instability of the distal joint, I use K-wire, of course, and I fix the joint in supination. But supination is not always the good position. So if the rejection is good and with no instability in the neutral position, I really do prefer to fix it in a neutral position. But normally it's in supination, of course. And I don't open the sorry?
For me, because Galeazzi fracture, if you have a DRUJ instability, it's because you have ligament lesion. So as soon as you have reduced and fixed your radius, I do the assessment of the wrist with an arthroscopy too, and I reattach the TFC because generally it is a peripheral lesion of the TFC. And after the reattachment, the arthroscopic reattachment, the stability seems for me sufficient. I don't use any complementary K-wire. But if I think that the stability is not so satisfying, so I put pinning too. But first, I treat the lesion as we treat the fracture associated.
There's one point, if I can make. Sorry, I'm Vijay from UK. One of the downsides that you can have after you put the K-wire, if it is not in a perfectly central position with the ball in the socket of the DRUJ, you could be keeping the DRUJ in a slightly unstable subluxed position. It is very difficult intraoperatively to be absolutely certain that it is in the center. The ball is in the center of that. So you could be keeping it unstable and preventing the natural healing. The other downside of putting a K-wire, in my opinion, is that the forearm rotation is a very strong force, and that may easily either overcome and break the K-wire or bend it, and that may create more problems than the problem that you started with. So one of the point you can say is that if you do put a K-wire, use a strong K-wire and make sure it is in the ulna head is in the center of the DRUJ, and have the tip of the wire protruding on the radial side, so that in case there is a breakage of the wire, it can be pulled out.
I agree.
So, Patrick?
I think we have come to the end of the session. Probably this was a wonderful session. The whole initiative was taken from our Trichy Ortho Club Secretary, Dr. Mukesh. He's supposed to be here, but because of his personal reason, he could not come. He was the one who initiated to have this specific topic, because the orthopedic surgeons, they have a lot of, things which we need to be understand, and things which need to get clarified. With this short conclusion, we thank Dr. Patrick, Dr. Didier, Dr. Frederick for the valuable time spent with us, especially on this day. And we are extremely grateful and thankful to you. Before stopping this meeting, I would like to share a few slides these are the next program which our Journal of Hand and Microsurgery is planning. So this will be the upcoming journal monthly meet, which will focus on the congenital hand difference. Please mark your dates, 23rd January 2021 at 7:30 p.m. of Indian Standard Time. We'll be sending you the flyers and we'll be sending you all the details. So meanwhile, thank you all, one and all, the panelists, the speakers. Have a great day. Good night. We will see you in another platform with a different topic. Thank you very much.
Thank you. Merci à tous.
Thank you. Au revoir.
Thank you. Thank you.
Oh, yeah, thank you.
Patrick.
Thank you, Arju. Thank you, Harshil. Sorry, I couldn't get you into the platform on time. Sorry, we will have some other time. Don't worry. And Dr. Ashok, thank you for joining us. We'll be privileged to have you here. We'll be keep continuing working together for a subsequent journal meet in the future.
Thank you.
Thank you. Bye.
Thank you.
Vijay for organizing. Vijay is the one who started the, getting all the surgeons into us. So we should thank you. Thank you.
Thank you, Vijay sir. Thank you. Thank you very much.
Good night. Safe. Thank you all. Good night.
Bye bye.